Moving on with dermatology. This is probably the most high yield of all the dermatology sections that we're going to be going over. Drug-induced hypersensitivity reactions, alright? And I made a really easy to remember chart how we can compare and contrast, and hopefully you guys can make a little sense of things that you mixed up commonly, alright? First, let's start off with urticaria. First things first, when does urticaria usually happen? It's a few minutes immediately after contact with an allergen, okay? Food allergies usually fit into this category. Now, how am I going to distinguish between acute urticaria and chronic urticaria? Time, okay? Chronic urticaria, 6 weeks or more, okay? Less than 6 weeks, acute. Persistence over 6 weeks, chronic urticaria, all right? What's my treatment? This is where it gets tricky, right? First, you want to identify your triggers and limit exposure to these triggers, all right? But my first line pharmacotherapy is actually diphenhydramine, Benadryl, okay? If it's life-threatening, you're going to add systemic steroids. So first, we got to identify triggers, limit exposure, first line diphenhydramine, add systemic steroids, all right? Next, we move to erythema multiforme. What do I want you to remember for this? Target-like lesions, okay? They're going to occur on the palms and the soles, and the most important predisposing factor is herpes. However, it can also happen in mycoplasma, okay? Mycoplasma is sometimes asked as well. Fungal diseases are also implicated, but not commonly tested on the exam. Now, herpes is the most common. Mycoplasma is also tested, okay? It can also be caused by drugs such as sulfa, phenytoin, barbiturates, penicillin, and allopurinol, all right? Treatment, erythema multiforme, first line diphenhydramine. Remove underlying cause, treat the underlying infection, all right? Next, let's go on to this painful disease, Stevens-Johnson syndrome. What do we remember? Stevens-Johnson syndrome, sulfa drugs, all right? Stevens-Johnson syndrome, sulfa drugs. That's your most common right there, okay? It presents similar toxic epidermal necrolysis, but it's a milder form, okay? So look at the presentation, milder form. Why? Because it's only going to involve 10 to 15% of your total body surface, all right? Sulfur drugs, okay? Also antibiotics, penicillins, phenytoin, phenobarb, and NSAIDs can cause it, all right? Treatment. This is very high yield, guys. Admission to the burn unit with removal of the offending agent. Got to support them with IV and symptomatic treatment. Symptomatic meaning NSAIDs, etc., okay? But you got to admit these patients to the burn unit. It's crucial, all right? So we said Stevens-Johnson's is a milder form of what? Toxic epidermal necrolysis. Now, why is this a more severe form? Look at the amount of body area it affects. 30 to 100% body area, okay? It's much more severe than Stevens-Johnson's, and it has a positive Nikolsky sign. What is a Nikolsky sign? Nikolsky sign is actually skin peeling off with pressure. Where else are we going to see Nikolsky sign? Anybody ever heard of pemphigus vulgaris? You remember that? Pemphigus vulgaris, you also get a positive Nikolsky sign. Just means you're going to put a little pressure on the skin and the skin's going to slough off, okay? Diagnosis. It's a clinical diagnosis, all right? Most accurate diagnostic test, skin biopsy. Once again, we're seeing that skin biopsy is our most accurate diagnostic test. Treatment. Remove the offending agent, and we want to manage these bad boys in a burn unit in the ICU as well. Remember, how are we going to tell these two apart? They're both going to present the same. This one, 10 to 15% of the total body surface area. This one, 30 to 100%, okay? This one, positive Nikolsky sign, all right? Both of them are going to get admitted to the burn unit, support and management. What's interesting about this one, second line is actually IVIG. For toxic epidermal necrolysis, IVIG can be used second line, all right? Next, erythema nodosum. Everybody remembers erythema nodosum. When do we see that? We remember it as a buzzword, sarcoidosis, right? And we usually remember it's in the shins, right? It's not only in sarcoidosis, actually. It's actually most commonly due to a streptococcal infection, all right? Now, it presents as tender nodules on the shins that are smooth and shiny, all right? They can occur anywhere there's fat under the skin, including the thighs, arms, trunk, and face. Most common is strep. So if our most common cause is strep infection, how are we going to work them up? CBC, ESR, anti-streptolysin O, urinalysis, throat culture, TB test, chest x-ray. All right? This is the most important thing. Anything that's bolded is the most important thing to know for the exam, okay? Most commons is huge on the exam as well. Treat the underlying disease as well as analgesics and NSAIDs. And those that don't respond to initial therapy, potassium iodide. All right? So this is your step 3 question right here. This is your step 3 question right here. This is your step 2 probably. This is your step 2. This might be your step 2, but these are your step 3 questions they like throwing at you. Your second lines or when they don't respond to initial therapy. Fixed drug reaction. Look at the words. Fixed drug reaction. It's fixed, okay? So why is it named this way? Because they recur at the same site every time you have exposure to that particular medication, all right? These drug eruptions are usually when drugs are taken intermittently, and they're usually sharp, demarcated lesions, and they're hyperpigmented after the resolution of your symptoms, all right? And they occur in the same spot every single time, so they're pretty easy, all right? And you want to discontinue your offending agents and give topical steroids, all right? So urticaria, what do I want you to remember? Most important thing, overview. 6 weeks. Chronic has to be at least 6 weeks. Identify your triggers. Give diphenhydramine if it's life-threatening. You go to systemic steroids. Erythema multiforme, target-like lesions, herpes simplex can also happen with mycoplasma, all right? They like asking mycoplasma on the test as well. Diphenhydramine, remove the underlying agent. Stevens-Johnson's and toxic epidermal necrolysis. They present very similar. What are you going to look at? The percent of body surface affected. 10 to 15 is Stevens-Johnson's, 30 to 100 in toxic epidermal. Okay, both of them get admitted to the burn unit, but second line for toxic epidermal necrolysis, IVIG. Erythema nodosum, we know it from sarcoid, but most common strep. Got to do the streptolysin O. Treat the underlying disease, of course, as well as NSAIDs. Those that don't respond, potassium iodide. Fixed drug happens exactly at the same spot every time they're exposed, okay? After the resolution, they get hyperpigmentation in that area. You want to discontinue the offending agent and add topical steroids. And I know we went over this a little bit fast, but you know how YouTube is. Got to limit the time, I think under 10 minutes, all right? So hopefully you got these down. These are probably your most high-yield derm questions you're going to get asked on the exam.